Let's go ahead and get started. It's my pleasure to introduce our Grand Round speaker today, Dr. Dent. I think almost everyone in the audience knows Dr. Dent. Just a little bit about Dan. He grew up in Florida, went to undergraduate at Duke, went back to Florida for medical school, and did his residency at the University of Tennessee in Memphis. Dan's been on the faculty here for the past 22 years. I got to know Dan whenever I was a fellow in Memphis. He's been critical to everything the Department of Surgery has done, and he's been a very important key leader in American surgery, particularly in American surgical education. He's the immediate past president of the Association of Program Directors in Surgery. He's on the executive committee of the American College of Surgeons Board of Governors and has really led the effort from the governor's side for improving postgraduate surgical education in America. Dan locally has been a key leader and mentor to medical students, particularly medical students when it comes to research. I doubt there's anybody in the institution who's done more to develop and mentor medical students for careers in research. And he's going to talk to us today on autotransfusion of hemothorax, which in many ways came from that effort. This was a summer student program that they came up with a very interesting, good idea to look and see it. Well, what is this hemothorax autotransfusion, and is there any data that it's better than blood? And it's my pleasure to introduce Dr. Dent, autotransfusion of hemothorax. Dan.
Right. Is this mic on? Yeah. All right. Can you hear me? All right. Is anybody in the valley? I don't see the valley folks there. Okay. All right. So thank you very much for that kind introduction. I'm going to try to make this about a 30-minute talk, which is what we're trying to do for our grand round, so we have plenty of time for M&M afterwards, and we'll see how this goes. On disclosure, I'm the chair of the Blood and Tissue Utilization Review Committee for University Hospital. And I mention this because I want to encourage you as your careers progress to be involved, whether you're involved with blood and tissue utilization review or NISQIP quality improvement or credentialing in your hospital or infectious disease management in your hospital, that sort of thing. That's what physicians need to do, and all of this research I'm going to talk about came out of my role on the blood committee. I'm going to talk about autotransfusion, give some examples and kind of the broad overview of autotransfusion, and then I'm going to get into some specific research that Dr. Stewart referred to that we've done on autotransfusion of hemothorax. So, autotransfusion is a medical procedure in which the lost blood of a patient is collected and returned to the same patient. So the patient functions as both the donor and the recipient is one way to think of it. And there are various forms of autotransfusion. We learned this on the blood committee as we tried to get a handle on the autotransfusion processes around the hospital. The most common one that we see as surgeons is intraoperative red cell salvage, and I'll talk a little bit about that. But there are also people that reinfuse blood potentially from orthopedic surgical drains. You can do isovolemic hemodilution, which is done occasionally by our OBGYN colleagues, where they take a patient who's a Jehovah's Witness or has some other reason for not wanting blood transfusion from another person, and they take their blood out, do the case, have them bleed at a lower hematocrit so they lose fewer red cells, and then give them their own blood back at the end of the case. There's people using platelet-rich plasma. Some of the gynecologists are doing this. I've heard of surgical oncologists doing this in breast wounds, where you take blood out, spin it down, and spin down the plasma and platelets and then put that back in as a hemostatic agent. And then again, it's the patient's own blood, and it's a form of autotransfusion. And then what I'm going to talk in a lot of detail about is reinfusion of chest tube output. So autotransfusion is intended for use in situations characterized by loss of a significant amount of blood. So the orthopedic drain, where you lose 250 cc's in the first 4 to 12 hours post-op, that's mostly serum, that's not worth autotransfusing. There's not enough red cells in there to make it worth the trouble. But it can be advantageous in cases with patients with rare blood groups, where you have a blood supply that's not all that rigorous and vigorous or robust. And so there are times when it seems like it probably is a good idea. So again, the most common form we do is intraoperative red cell salvage. And this is in a trauma laparotomy in a patient with a busted spleen or a busted liver, or in a ruptured abdominal aortic aneurysm. There are cases where we do this. And you collect the blood, but you'll notice the suction tubing to collect the blood has additional ports on it, additional holes. And that's because you have to run an anticoagulant at a slow drip down to the tip of the suction, so that when the blood gets suctioned up, it mixes with the anticoagulant and doesn't coagulate. Okay, and the two anticoagulants used across the country are heparin and citrate. You then take what you collect and spin it down and centrifuge it and concentrate the red cells, and in theory wash out the anticoagulant and other potential factors like cytokines I'm going to talk about a little bit later. And then you take those concentrated red cells after you've spun them down with the centrifuge, and you hand them to anesthesia, and they hang the bag and they infuse it. And when you do this, the American Association of Blood Banks, the AABB, has some policies that you have to follow if you want to get AABB certified. Okay, there are a number of hospitals in San Antonio doing this that are not AABB certified, including University Hospital. And the reason they're not AABB certified is because it's a very expensive inspection process that you have to pay for. And when you do it, you have to prove to them that you have a quality control process for all autotransfusion processes, whether it's orthopedic drains or anything else. And at University Hospital, we tried for years to get a handle on platelet-rich plasma and orthopedic drains and things like that, and we never could get a good enough quality assessment process to get approved by the AABB, so we never actually formally applied for the inspection, although they do a lot of things at University Hospital to monitor the quality of this process that are not done around town. There are a number of places in town that just put the blood back in and never check their specimen in any way to see if it's any good. And so there's some questions that are raised that you have to ask, like, are the anticoagulants washed out? Did you lysol the red cells? Is it just free hemoglobin, which can then go damage kidneys and cause renal failure? Maybe you're doing the patient a disservice. What's the hemoglobin concentration in the product you're giving back? And really, does any of this matter? So at University Hospital, we've decided that hematocrit is important. It has to be a hematocrit of 55 or higher. Any hematocrit below that, it falls out as a quality indicator, and we go look at the machine and the person using the machine to see if there was a problem with the wash. Also, albumin should be washed out. We did some studies on the albumin. Citrate and potassium are well washed. We showed that. And bacteria are filtered out. So there's a few articles in the literature that try to guide us in our use in various subspecialties of surgery. In vascular surgery is a paper written about 13 years ago that said the conclusion was cell saver techniques often do not prevent the need for transfusions, nor are they very cost effective. Therefore, their use should be considered on a case-by-case basis. So not strongly advocating for it. In trauma surgery, there was a prospective randomized trial published about 10 years ago. And what was interesting to me in this group was that they actually did not think of bowel injury as a contraindication. So if you envision a blown out colon and a ruptured spleen and a belly full of blood and poo, They would put that in their cell saver machine and wash it down and give the red cells back out of that. And they found no problems. They did not find any bacteremias. They did not find any difference in mortality, but they also didn't find any benefit. And so some people have now not considered bowel injury as a contraindication to autotransfusion. I can tell you we do here. To my knowledge, we've not done a case with a bowel injury because, in my opinion, as just a reader and thoughtful, I hope, interpreter of literature, I want to see a number of these papers come up and show me that it's safe, not just one, before I start giving that back to my patients. In one series published 7 years ago in Archives of Surgery, in case match controls, they were able to show that they reduced transfusions and saved a little money by using autotransfusion. Again, this is washing cells and doing intraoperative red blood cell salvage. In cardiac surgery, it's routine. It comes with the bypass pump, basically, because you're suctioning out blood. The blood is heparinized. You can wash it down. At the end of the case, when you reverse the heparinization, you can give back the red cells. It seems to be effective, although to my knowledge, there's not been any great prospective randomized trial where they did on-pump cases, particularly without autotransfusion. So when you think about it, there's a lot of potential risks, a lot of potential benefits. The benefits are it's immediately available. It can maybe decrease red cell use from your blood bank. It has potential to decrease cost. And people talk about in stored red blood cells a storage lesion such that the red blood cells don't offload oxygen as well. And so your own blood, which hasn't been stored, shouldn't have that storage lesion. On the other hand, if you lyse the cells, now you're giving free hemoglobin. You might be giving cytokines to the patient, which could make the patient have a septic shock-like picture. And there's potential for contamination in the process, although there's potential for contamination from the blood bank as well. So we were at our committee meeting talking about autotransfusion, and we had done it a few times. And we had an interesting discussion where the clinicians in the room said, absolutely, I'd like to autotransfusion because I don't want somebody else's blood in me with the risk of HIV and hepatitis. On the other hand, the blood bankers said, look, we know the blood bank processes. They're incredibly safe, incredibly rigorous. I would much rather have units of blood bank blood than that stuff that might have a cesspool of inflammatory mediators that you guys are taking out of the Pleurovac and putting back into patients. So this discussion led us down a path of research that, as Dr. Stewart mentioned, was really driven by 3 medical students who, over the course of 4 summers, spent their summers collecting specimens, running specimens, and getting lab results, writing, presenting, and first authoring a number of papers that I'll show at the end. So the first question was, is that stuff in the Pleurovac as good as fresh whole blood? Because while this discussion was going on, data was coming back from Iraq and Afghanistan that showed fresh whole blood transfusion was incredibly helpful. And if this stuff had all the clotting factors and platelets and everything else that comes with fresh whole blood, then it would potentially be extremely beneficial to do autotransfusion. But mostly we wanted to know some of the hematologic results, and we also want to know, when we're counting 1-to-1-to-1 resuscitation, if you give back 2 liters of Pleurovac output, how many units of red cells does that count as? Should it count as FFP as well? And so we weren't sure, and in this era of trying to do hemostatic resuscitation, we were curious about this. So we got 32 patients that had chest tube output, and we took the blood out of their Pleurovac, and we compared it to their venous lab values that were drawn for clinical care. And we found that the pleural blood, as we called it, had a hematocrit of 26, hemoglobin of 9, which means there wasn't a lot of lysis in this at this point, and a platelet count of about 50. And all of these were statistically significant compared to the patient's venous values. Then we looked at the coagulation profile, and none of the pleural blood would clot. 32 patients, INR was immeasurably high every time, PTT was immeasurably high every time, fibrinogen was immeasurably low every time, okay? So this blood would not clot. its factor 8 level was low, its factor 5 level was immeasurably low, and the D-dimer was immeasurably high. And we looked at some other things as just to see what else might be in it. And we found, for example, the potassium was statistically significantly higher, but clinically irrelevant because both of these values are in the normal range of potassium. The AST and ALT were a little higher, but we see patients with liver and biliary disease with AST levels as high. And I don't think AST floating around is necessarily harmful at that level. So we published this paper with Mark Salhanek, who's now a fifth-year resident at UT Southwestern, going into vascular surgery, as the first author, and he presented this at the Southwestern Surgical. And we concluded that at 4 hours after evacuation, and the AABB says you have 4 hours to put this stuff back into someone. It's basically very dilute whole blood. There is some hemoglobin in it, but it really doesn't clot, and you can't really count on it to have clotting factors. So we decided it should not be considered a substitute for whole blood, and if transfused, you're going to need to add some clotting factors to it. So the next question was, is 4 hours the right time frame? Maybe we should do this faster, because in most clinical practice, just for the students, when somebody dumps 1,500 or 2 liters out of their right chest into a Pleurovac, we don't wait 4 hours to put it back in. It typically gets given sooner. And so we wondered if sitting around out to 4 hours made much difference. And then we also wanted to, because we did this as a multidisciplinary project with hematologists from the blood bank, they wondered, why won't it clot? Is it just factor deficient, or are there some inhibitors present as well? So they suggested some studies that we didn't know existed, and which is why multidisciplinary research is a good idea, to look at this. So again, we enrolled patients that had enough blood in their Pleurovac for us to collect at 4 different time points, and then analyzed some of it immediately, and then we did a laboratory mixing study, which is something that the hematologist had to teach us about. But the bottom line is that if you have a patient with an inhibitor, a clot inhibitor, and you mix it with normal plasma, and that's the whole thing, we're going to mix the patient with normal plasma, that inhibitor will inhibit clotting. On the other hand, if you have a patient who's just deficient in clotting factors, and you mix it with normal plasma, you'll actually get fairly normal clotting results when you mix these two together, because you can make normal clot even though you have half as much clotting factor. To really get your INR, your PTT prolonged, you have to have a real dilution in clotting factor. So if they're just deficient, they should make normal clot. And in patients that have clot accelerators, which was not our specific question for our patient population, but you can actually accelerate clot if you mix it with normal patient plasma. So we did this, and we did it at what we thought were clinically relevant dilutions, and the idea being that the average person has a circulating blood volume of 5 liters. So if you mix a 1,250 cc autotransfusion into a 5-liter blood volume, that'd be about a 1-to-4 ratio. So we figured somewhere between 1-to-2 and 1-to-8 would be the correct ratios. And first we confirmed our previous results that nothing clotted at hour 1 or hour 4, which was part of the purpose of the study. It was to see if at hour 1 things were different. Maybe it was sitting there making clot over time and using up the factors. And then when we did the mixing study, we found that the PTT at dilutions of 1-to-2, 1-to-4, and 1-to-8 particularly was way below normal, statistically significantly below normal. So it clots faster. So we weren't thinking there might be any accelerators in this, but there actually is some clot accelerator in the blood in the Pleurovac. And when we looked at this numerically, we looked at INR and PTT. If you look at the 1-to-4 ratio, both the INR and the PTT are statistically significantly lower, meaning the clot forms faster. Even though this stuff by itself won't clot, when you mix it with some normal plasma, it makes a clot faster than normal. It makes you hypercoagulable at dilutions that would be expected to go along. So this was the second paper we published. Zach Smith is now a neurosurgery resident. We looked at characteristics of hemothorax at 1 hour and 4 hours, and then we also found that hemothorax is hypercoagulable when mixed in serial dilutions with normal pooled plasma. So step 3, we looked at mixing with the patient's own plasma, because when you autotransfuse, you don't mix with normal plasma out of the blood bank. You mix the patient with their own circulating blood at that time. So we got some blood that was left in the bottom of the test tubes from their standard laboratory tests, and we mixed it with what came out of their Pleurovac in this study, and did basically the same tests. And again, here's the idea of the mixing studies. And what we found was at 1 to 4 in particular, when you mixed it with the hemothorax with the platelets plasma, the average PTT was 21.7 seconds, which is about 10 seconds faster than normal. And this group was statistically significantly hypercoagulable compared to the normal platelets plasma, the patient's own plasma at the time, or the mixture with normal plasma. So we found that hemothorax is incoagulable on its own, which was consistent with our previous studies. We confirmed that. But when you simulate autotransfusion by mixing it with some of the patient's own blood at that time, at a clinically relevant dilution of 1 to 4, the resulting mixture becomes hypercoagulable. So we did another study. We worked in collaboration with the trauma hematology group over at the Institute of Surgical Research here in the military in San Antonio. They've done some very interesting work. And we looked at inflammatory mediators, looked at cytokines to see what's going on with cytokines in this stuff, and trying to figure out if this is something you would want transfused back into you or not. And long story short is cytokine levels are extremely high in what's in your Pleurovac. And so these are normal serum levels in this left column on all of these graphs. Okay, normal in injured patients, not normal volunteers. Okay, of IL-6, IL-8, TNF alpha, and GM-CSF. And if you look at what's in the specimens over 4 hours, some of them more than double over the 4 hours, at 1 hour, 2 hours, 3 hours, 4 hours. So the cytokine levels are extremely high in blood that comes out of your Pleurovac, which shouldn't be too surprising. You're an injured trauma patient, and this is coming out of the injured tissue into your left or right chest, and then a chest tube is placed, which injures more tissue, and then you drain it out into the Pleurovac. Interleukin-2 and interferon gamma were also significantly elevated compared to intravenous controls. IL-4, IL-10 also elevated, and rising with time. So, looks like I made the time deadline. The publications that have resulted from this, we've got 4 so far. Medical students were first author on all 4. Mark Zalhanik has continued to be involved from Dallas with the last project. And in addition to all the co-authors, this is obviously, there are names on here that involve hematologists from university, lab technicians from University Hospital, trauma surgeons from University Hospital, students, PhD researchers from our Health Science Center, and then researchers from the military as well that partnered with us on these projects. So I want to thank all of them, and then also acknowledge a lot of the people that have done a lot of the work to lead to these publications and help us go down this path of research that all started from me being appointed to a committee. So again, get involved. When you get asked to serve on a committee, even if it's not of your particular interest at that time, go learn about it, okay? If it's something you know nothing about, it'll help fix a deficiency in your knowledge base, okay? So be involved. And to summarize, there are a variety of processes that you can do autotransfusion. I've talked a little bit about intraoperative red blood cell salvage, which is the most common process. I'm pretty convinced, based on work out there, it's safe. I'm not 100% convinced it's cost effective or advantageous, although we do it for big trauma cases, and I think that's appropriate. The cardiac surgeons do it for virtually every pump case. I know they do it for some vascular surgery cases. Ortho occasionally does it for big cases, redo total joints, things like that. So there is a role, it's being used, and I want to make it clear now, between the chest tube studies that we did that showed all the cytokines and clotting problems versus the red cell salvage where you wash the cells and wash out the cytokines, we haven't proven that yet, but we've proven it on molecules of the same molecular weight. We've proven it on albumin, we've proven it on gentamicin, we've proven it on citrate, we've proven it on a number of things. They do get washed if the wash is done properly. So intraoperative red cell salvage is just red cells and is a very different process from autotransfusion of what's in a Pleurovac straight up without the washing process, which is the way that's typically been done. So thinking about washing hemothorax down the road is one possibility when you've got 2 liters in a Pleurovac. Rather than giving it straight back, you might want to wash it and give the red cells. There are also processes, as I mentioned, that I didn't go into much, reinfusion of output from surgical drains and isovolemic hemodilution. But to me, the key is it's important to understand and monitor whatever you're doing. You need to know what you're giving back to your patient. And we've been doing it for a long time, really without knowing much about what we're giving back to our patient. And so you need to know what you're doing. And although hemothorax is an attractive source of red cells because it's sitting right there next to the patient, we don't generally recommend it, and we basically quit doing it, partly as a result of these studies. But partly because we have a very robust blood bank support. And if you're in a remote environment where you don't have blood bank support, autotransfusion of hemothorax might be a great option. It might be the right option. But if you're in a place that has good blood bank support, and I can tell you just anecdotally, in the early to mid 90s as a resident, when most of our resuscitation was massive crystalloids, and we saw a lot of coagulopathy, dilutional coagulopathy in our trauma patients, when we gave 1.5 liters or 2 liters of hemothorax back to a patient, they quit bleeding. They looked magical. It seemed like great stuff. But now that we're very proactive with our resuscitation, giving fresh frozen plasma and platelets much earlier, I don't think reinfusing hemothorax has as much a role as it did in practice 20 years ago, due to the potential for hypercoagulation and cytokines. There's still a lot of unanswered questions. You know, what's the minimum volume? If you're going to do red cell salvage, what's the minimum volume makes it worth doing? If you get 1 liter of blood out, are you going to give back maybe a unit or maybe even up to 2 units of red cells back? Is that worth doing? Is that worth the cost of opening up the machine and calling in a tech and that sort of thing? Nobody knows the answer to that. What are the potential dangers of autotransfusion, and how does that compare to the potential dangers of the components we get from the blood bank? And why is this routinely done around town and in a lot of places without any real monitoring? And should autotransfusion of unwashed blood be abandoned in areas with blood banks? So with that, I'll be happy to answer any questions, and thank you for your time and attention. Thank you. Yes, Brian.
Again, good talk, especially just about the principles. With respect to the hemothorax, what if you're in a circumstance where you didn't have the robust resources of the University Hospital? Should they be using this on the battlefield? Should we be using this for MCIs?
Absolutely. I'll tell you, it was very interesting. I was at the Austin Trauma Conference a couple of years ago, and Peter Ree was there, and I gave my talk, and he had never heard anything about this, but he was about to show his work on using 14 French chest tubes, you know, little pigtails, basically, 14 French pigtails, and they have not used a larger chest tube than a 14 French pigtail for years. And he maintains that it's either clotted or it's not. If it's not clotted, it'll come out through a 14 French pigtail, and we don't need to be putting in 32 and 36 French chest tubes. And he showed a video of a patient that He said he was in the operating room. His resident came to him and said, I got this guy that's shot in the right chest who needs a thoracotomy because he's got 1,600 cc's out in his pleurovac. And heart rate's 85, blood pressure is 120/80. He's not intubated, he's awake and alert and saturating 100% on room air. And so Peter Ree finished the case, went down, looked at the patient, actually took a video of the patient. The patient looked as calm and well as any of us in this room. He showed the monitor, he had normal vitals, and he showed the pleurovac, and by that time there's 2.1 liters in the pleurovac. So he auto-transfused the 2.1 liters in the pleurovac, and then the chest tube output stopped. And it occurred to him, based on my talk that I'd given an hour before his talk, that maybe the reinfusion is what made him hypercoagulable, which made him stop the bleeding. And so he walked away from the talk thinking we should be doing more of this because it'll make our trauma patients stop bleeding. But that being said, I think your assessment is exactly right, that I really, at least at University Hospital and most American blood banks, I trust our blood bank. We know what we're getting. And now that we're doing proactive, 1-to-1-to-1 ratios of red cells to FFP to platelets, we're not seeing the dilutional coagulopathy we used to see in trauma patients. And so I don't think that this has a role in that setting. But in the setting where you have limited resources, I think it could be, it's a good form of oxygen carrying capacity. It may help someone who's on their way to a dilutional coagulopathy actually make clots. And so I think I would definitely do it in that setting. Yeah. Other questions?
Question.
Yeah.
Another thing would be outside the scope of your talk, but I know there was a lot of research on synthetic products for oxygen carrying capacity, et cetera.
Right.
Have there been any relevant clinical applications that are coming up?
No, we were involved in a couple of those trials. And what he's talking about is plasma-free hemoglobin, which some people say is a marker for a risk for renal failure, and other people say, no, it's the answer to the future. And there were two sources out there. One was from expired human banked blood, and they would take these cellular components off and get just the hemoglobin. Others, another company had its own, they had a bovine breed of cow that had no cow viruses, and they would use cow blood and get rid of the antigens and so forth. My conclusion, and Dr. Stewart was involved in some of these studies as well, my conclusion was it had reasonable oxygen carrying capacity for a day or two, but because it wasn't carried, a red cell lasts about 10 days. Free hemoglobin lasts less than that. And so we would actually see the hemoglobin level drop over 24, 48 hours. So it would get you, if you were in a place that had no red cells, and tomorrow, the next day, you'd be in a place that did have red cells, then it seemed like a reasonable thing to tide you over to get there. But we saw MIs and other things as the hemoglobin levels plummeted, and we saw a number of complications related to it. So neither one of those really got off the ground because their studies didn't really show any benefit. So
They actually showed harm.
yeah.
They actually showed harm. The pleural hemoglobin is a good idea. It's a good idea, but there's likely something about it that causes vasoconstriction in, particularly in coronary
Vessels.
And I think that trial, if it would have been done in a different subset of patients, the conclusions would have been different. If it would have been done in patients who refuse any blood transfusion, that's sort of getting to your point of
Jehovah's Witnesses.
What would you do? And what would you do in an austere environment? Well, I mean, that's not where you are now, but you might do it differently. But for routine clinical use, unless it can be shown that there's not the toxicity of the vasospasm, I think it's never going to really make it to clinical practice.
Yep. Yes, Ed.
You mentioned that there was a statistically significant.
Push the button so the folks in Harlingen can hear you. Or I can repeat your question either way.
You mentioned there's a statistically significant difference in the profile of the cytokines and the coagulation factors in the chest tube blood, do you have any sense, is that a clinically significant difference? Like if I give you a unit of chest tube, is that like getting really bad pancreatitis or just...
I can tell you the handful of times I've done autotransfusion, I did not see sepsis-like results from doing it. I don't know off the top of my head what the standard circulating blood value is of TNF or some of those cytokines in a patient with a bad pancreatitis or a bad septic picture. That's a good question. But in the handful of times I did it as a resident and as a faculty member where we auto-transfused, I don't recall the patient getting septic. I actually recall them getting better, to be honest. And like I said, in the early to mid-90s, it seemed like a good thing, but that's when we were giving people liters and liters of crystalloid and seeing a lot of dilutional coagulopathy in the trauma patients. So, yes, Abdul.
What are your theories on how the blood changes from an almost anticoagulant state to a procoagulant state once you transfuse it into the body?
So, good question. What I think has happened is we all remember the blood clotting cascade. I'm not saying we all have it memorized, but we all know it exists, okay, and there are steps in the cascade. And what happens is, in talking to our blood bank colleagues, is as the clotting process goes through those steps, a couple of the molecules get totally used up and are no longer present, such as fibrinogen and factor V that we showed in the first study we did. The step above it now can't go. And one thing that can't be done worldwide, you can't measure activated factor VIII versus unactivated factor VIII or activated factor V versus inactivated factor V. Nobody has the capacity to do that yet. And what they think is a number of cytokines are built up and activated and ready to rock and roll, but they have no fibrinogen and no factor V. So at a couple of steps along the way, it gets stopped. The moment you give them some fibrinogen or factor V by mixing it with normal blood that has that circulating in it, it revs up the clotting cascade and really makes a clot really fast. Yes, ma'am.
So similar question. In your mixing studies, did you use patient-matched normal blood? So did you take Pleural blood and mix it with your patient's peripheral IV drawn blood, for example, to see if the hypercoagulability is actually a difference between donor blood versus just stress?
We did. And in the, let me see. Right here. So actually, no, I'm sorry. We mixed hemothorax with normal plasma and hemothorax with patient plasma. We did not mix patient plasma with normal plasma. Is that what you're asking?
Or just, I guess I didn't appreciate that in the slide when I saw it earlier. I just wanted to know if the mixing studies were patient matched or if they were all like donor bank blood.
Right, no, so the second study was with donor banked plasma. But then we realized mixing it with donor bank plasma is not exactly the question we were asking. So in the third study, we mixed the hemothorax with the patient's own plasma. And that's when it got even more hypercoagulable. Okay, so good question. Yes, Dr. Pruitt.
Very interesting. Dan, put this in a context of the systemic hypocoagulability that follows injury. Yet you have a compartment where there's hypercoagulability. And is that totally cytokine effect?
So I don't know that we're seeing hypocoagulability really anymore now that we're doing hemostatic resuscitation. I really think that was a dilutional coagulopathy, most related to massive crystalloid resuscitation and being too late. You know, back when I was a resident, we didn't give FFP until the INR was abnormal, until coagulopathy had already set in. We used to treat coagulopathy. Now we're prophylaxing against it. And so we're not really seeing the coagulopathy much anymore. So, yes, George.
Lovely talk. And one question, how about we have a lot of people with cancer? How does this people with malignancy, let's say run to a trauma, do they behave the same? Are they more, they are usually hypercoagulable.
Right.
So
So I don't know the answer to that. I mean, I know cancer patients at baseline are hypercoagulable. Trauma patients at baseline, once they're done with their resuscitation, tend to be somewhat hypercoagulable at risk for DVTs and PEs. I'm not aware of any large series of cancer patients who underwent trauma to see if that's accentuated in that patient population or not. Yes, Michael?
Do you think that the container has any effect on this coagulation derangement, or is purely just the result of injury?
No, it's a good question. The question is the lining of the container a nidus for clot formation, which then uses up all the clotting factors as it just clots to the walls of the container? And that's a good question that we don't have a good way to answer. I can tell you that in the Pleuravacs, they make an autotransfusion Pleuravac, which has a heparin bonded lining, in theory, to not make clot in there. We have not tested that against the standard Pleuravac to see if it really makes a difference or not. But you can buy Pleuravacs, you can buy the autotransfusion Pleuravac, it's a little more money. And you got to figure out when you want to use it. Now that we've kind of quit using it, we don't have any of them anymore. But you could, in theory, test those against regular Pleuravacs and see if the results come out differently. Yes or no?
Was this tested, like the autotransfusion, it was tested against like blood transfusion? What about against crystalloid? Is it better to give autotransfusion resuscitated fluids or the crystalloid? Was it tested for this?
Not aware of any study that specifically did that. I mean, what they did was, in the studies that were done, they compared, we're going to resuscitate both patient populations the way we would normally resuscitate both patient populations to the same endpoint, certain hemoglobin levels, heart rate, blood pressure, et cetera. Just in one group, they allowed autotransfusion, the other group, they didn't. So both patient populations got a mixture of crystalloid and blood bank products, and one group also got autotransfusion products, and they found in some of those studies it reduced the number of blood bank products you needed to use. That was in washed red cells in trauma laparotomies. But in terms of just comparing that to crystalloid, there's only a certain amount of anemia people are going to feel comfortable with, so they're going to transfuse something when you start getting too anemic. And if they're not on the autotransfusion arm, then they'll just use red cells from the blood bank.
A simple conclusion, and just throw this out. Would you agree that unless you're in an austere environment where you have no blood available, we shouldn't be giving unwashed pleural blood to patients?
Agreed.
You can wash it.
Agreed. I would not want, as a patient, unwashed blood, whether it's abdominal blood or pleural blood or whatever, if I'm in a place that has blood bank resources. But I would gladly take washed blood. And not thinking necessarily that it's superior, but thinking that it's a good option and probably as good as what comes out of the blood bank. All right, thank you very much.
Okay, if you stretch your legs for a minute, and we'll start again.
Okay. Pressure's already up. It's up, I just want to make sure. Okay.
And the only one that's not set up.